So, like I said, in Infertility Teaching Hospital, semen analysis is usually done first, and if there is any abnormal findings, a thorough physical examination is subsequently carried out. So if there is low sperm count, then we have to do Valsalva maneuver to find out what is happening. Okay, so in investigating infertility, we can approach this in two ways. We can investigate firstly the female factor infertility or infertility associated with the female, and also investigate the male factor infertility or infertility associated with the man. In investigating female factor infertility, there are routine tests and also specific tests to be done. Of the routine tests, we have full blood count, fasting blood sugar, urine analysis, and also sickling status. So by this, we want to know how blood flows, if it's a woman, to the ovarian artery. How is the ovarian artery nourished by blood? Spermatogenesis needs blood to take off. We also need energy to produce the egg. The mitochondria will need energy and those things. So if the person is diabetic, it becomes difficult. The urinalysis also, is there any infection that can affect the uterus and cause, infection can lead to anovulation. Infection can lead to infertility in women. Sickle cell occlusive, vaso-occlusive disorders can also cause infertility. That is when blood vessels are occluded or blocked, can cause infertility. So let's see. So specific tests, we have finished these are the routine tests. So we are now going to the specific tests to be done. And the specific tests to be done are, we need to confirm ovulation. So we use the basal body temperature charting. It is not so very much good in predicting infertility in Ghana, because in infertility, how many of our women in Ghana are educated to be able to chart their temperature, basal body temperature? And also because of malaria, malaria leads to paremia, it leads to pareuria, it leads to high body temperature and the rest. So you cannot be, when malaria is frequent or very high prevalence in sub-Saharan Africa, so it becomes difficult to produce a lot of heat. So it becomes difficult to chart the basal body temperature. We also look at mid-luteal or mid-cycle or mid-luteal phase serum progesterone, meaning that mid-luteal occurs around day 21. Last time I was telling you in the physiology of female reproductive system that we have the 21-day progesterone. Progesterone that is determined or tested or measured within 21 days, because at the 21st day of the normal 28-day menstrual cycle, the 21st day is the day, or the 21st day is the day that you can get progesterone to be very high. So we have to measure and see whether progesterone is going to be very high. So if the value of, so we estimate this one 7 days before the onset of menstruation. So 7 days before the onset of menstruation, we are supposed to get serum progesterone level. So if value is so high, that's above 30 nanomole per liter, it is very likely that there is adequate ovulation. But if the value is lower than 30 nanomole per liter, then we repeat the test in another cycle. Please, this unit can change based on the kind of reagent and the machine we are using. We also have mid-luteal phase endometrial biopsy. So when the 21-day progesterone, when the blood is taken and we test for the level of this hormone progesterone, we can at the same time take a biopsy of the endometrium. We just take a simple biopsy. Is what? Biopsy, when we say biopsy, Biopsy is if you want to find out whether there is any cancer or abnormality or disease in, when you want to find out any disease in a tissue, whether it's cancer or benign, whatever, then we take a biopsy. So biopsy, these are investigations wanting to find out whether there is any malignancy of a tissue, whether there is any cancer of a tissue, malignancy of a tissue. So this is biopsy. So we take a tissue specimen, just a small tissue specimen, and do histopathology to find out what the disease associated there of the tissue, whether there is any malignant lesion there, we find out. So that is biopsy. So we take the biopsy of the endometrium. We take the biopsy of the endometrium to find out whether there is any endometrial hyperplasia, abnormal growth of the endometrium, and see. So for this one, we are able to elucidate whether there is what, for the biopsy of the endometrium, we are able to elucidate whether there is endometrial cancer. Endometrial cancer. And endometrial cancer will lead to a lot of profuse bleeding. And this one will lead to what? Excessive bleeding. When you are always bleeding from your vagina and it is not your menstrual cycle time, it is not your menstruation period, that means that you can get cervical cancer or endometrial cancer, which is as a result of excessive bleeding. So we have to take a section of your endometrium and go and do histopathology. We take a biopsy of it and go and run histopathology to find out the cause of the endometrial, whether there is endometrial cancer or not. So we have endometrial cancer. Endometrial cancer. So we can also do ultrasonography. This is helpful in detecting whether there is polycystic ovaries, luteinized unruptured follicles, and endometriomas. So when we say polycystic ovaries, or also called polycystic ovarian syndrome, we can see this is a normal ovary. We can see that the polycystic a cyst is a collection of fluid. Like I said earlier on, a cyst in medical parlance or medical term is collection of fluid. And this fluid can be and this fluid can be, the fluid can be blood, it can also be pus. So any fluid at all where it's not supposed to be, and the fluid comes to accumulate there, we call it a cyst. Some of them smell, some of them are infected. So we see this normal ovary, but this ovary contains small pocket which is full of fluid, infectious fluid. We call it polycystic ovaries or polycystic ovarian syndrome. So on ultrasound, this is what you will see. Small pockets at the edges of the ovary. Small pockets filled with fluid, which is infection. And some of them, the polycystic ovarian syndrome is genetic. So if you are a woman and you have polycystic ovarian syndrome, which is bilateral. Bilateral means that you have it on your left kidney and also on your right kidney. Your left ovary and also on your right ovary is bilateral. That means that if you have a child already, then you have to thank God because you are not going to deliver again, because your ovaries cannot produce oocyte or eggs. You cannot ovulate. So we have bilateral polycystic ovarian, we call it polycystic, PCOS, polycystic ovarian syndrome. So I know one lady who is a friend. She delivered the first child. Then later we found on ultrasound that she has polycystic ovarian syndrome. so she will not deliver again. So, but if you want to still deliver, you can still force and deliver. Anything can happen in life. Most of the time they give them metronidazole and other things to take to control it, to control the infection. These are polycystic ovaries. Polycystic, you can see the cyst. A cyst is a collection of fluid. You can see any dark environment on ultrasound is what any collection of fluid on ultrasound appears dark, and the places that appear bright is what we call the tissues. The tissues. So this is the fluid is anechogenic. It doesn't reflect any sound, so it's dark. So all these dark patches are the follicles which contains fluids. So it's difficult, and so the eggs or the follicles are so small because it's full of fluid, so it's not able to produce the ovum or ovulate. So let's continue. So, and also, like I said, luteinized or ruptured follicles. So if your follicles are not able to rupture and they become filled with lipid that's luteinized, then they cannot ovulate. Endometriosis. Endometriosis is what? The endometrial tissue can go and attach to your kidney, can go attach to your heart or liver or anywhere. So it becomes malignant endometrial tissue. That is what we call endometriosis. And if this the endometrial tissue has gone to attach to the ovary or the fallopian tube or any part of your body, it has traveled and it has a lot of fluid collection, or it has a cyst, then we say endometrioma. We will also investigate this by letting the woman do luteinizing hormone monitoring. So you look for LH hormone in the woman's urine to be able to find out whether she is prone to infertility or not. So let's investigate the cause of anovulation or your inability to ovulate. If serum FSH and LH in early follicular phase of menstruation is low, so serum prolactin 2, you know, when you are breastfeeding, doing exclusive breastfeeding, the whole of the 6 months, you cannot pick a seed, you cannot become pregnant because high prolactin levels suppress follicle stimulating hormone and luteinizing hormone production. Thyroid function test is also very important. Why? Because the T4, which is called tyrosine, T4, which is called tyrosine, when it is high, when the T4 is low, it will increase the amount of prolactin your pituitary gland makes, and this can be as a result of thyroid surgery, Hashimoto's thyroiditis, radiation therapy, medications such as lithium. All the meaning of this is that if your T4, your thyroid hormone levels are low, it can affect your fertility because thyroid hormone level influences the level of prolactin, or it influences the level or concentration of prolactin that is produced by the mammary glands and so forth. So by the anterior pituitary. So if your thyroid function test parameters are low, you will know that it will increase the level of prolactin that is produced, and the higher level of prolactin too will reduce the concentration of FSH and LH, or it will suppress FSH and LH production, which will lead to infertility. So we can also diagnose, we can do biophysical test. And these biophysical tests we can do are, we can also do biophysical tests, biophysics. We can also do biophysical tests. That's physics and biology put together. Biophysical tests are also called radiological investigations. Radiological investigations. investigations. So radiological investigations can also be done. So radiological investigations can also be done. Radiology. So by way of radiological investigations, what are we looking for? We will do X-ray. We will do X-ray, computed tomographic scan, magnetic resonance imaging of the pituitary fossa or the pituitary gland, and we also do karyotyping. We study the chromosomes of the mother to find out whether she has any abnormalities. Then we assess the patency of the tubes. But that is, when we say salping is what? Salping is what? Initially I said salping. So salping or salpings is what? Fallopian tubes. Fallopian tubes. So the woman's fallopian tubes. Fallopian tubes. That is what we call salping. So the fallopian tubes. So we assess the fallopian tubes. So we said hysterosalping. We'll do hysterosalpingogram. Hysterosalpingogram provides an outline of both the uterine cavity and the fallopian tube. So we want to see what goes on in the uterine cavity and what is happening in the fallopian tube. Are the fallopian tubes blocked or they are patent? Is there something that is obstructing or blocking the fallopian tubes, or it is patent? That patent means that there is nothing blocking it. So this is an X-ray. So when you are in your lab and they bring HSG, that do HSG, it means X-ray. X-ray, they give the woman a dye, and for about 30 minutes they will do the X-ray to look inside her fallopian tube and also the uterus. So hystero means uterus. Hystero. Hystero means what? Uterus. Female uterus or womb. So if they say you are doing a woman, you go to the hospital gynecological unit, they say you are doing hysterectomy, meaning the total removal of what? Hysterectomy. Total removal of the uterus. Hysterectomy. Removal of the female uterus by surgery. Maybe your uterus or your womb is full of cysts, or your womb is full of fibroid. Fibroid is called myoma. And if it is plural, they call it my spelling is not coming up. Plural of fibroid, we call leiomyoma or myomata. Leiomyoma. Anytime you hear myoma, it's what? Fibroid. And if you add matter, it becomes plural. So myomata is plural. Then leiomyomata is the same thing, plural. So if your uterus is made up of a lot of fibroids, then we have to remove all of them so that it will not lead to cancer and the rest. And that is what we call hysterectomy, total surgical removal of the uterus. So like I said, so hysterosalpingogram is what? You give the woman a dye so that she will swallow it or drink it. Then you will be able to see the uterus and also the fallopian tube in a graphical format and see whether there is any blockage. And this is done in X-ray. Laparoscopy with dye intubation means that you are going to do surgical procedure where you give the woman a dye. A dye. You put the dye in the tubes, and so that you can be able to visualize her uterus, her fallopian tube well. And so this is done in HLT, hysterosalpingogram, or chronic pelvic pain. So most of the time if you have chronic pelvic pain, you can do it. Points to note on HLT and laparoscopy with dye intubation is that HLT visualizes the uterine cavity alone. Results: radiographs of HLT are always available for reference. Laparoscopy is more observer dependent. HLT results in exposure to X-ray radiation, so it is not good because X-ray radiation, you know, it can cause cancer and a whole lot of defects. HLT doesn't allow visualization of other pelvic structure for pathology. It's only the uterus and the fallopian tube, not other pelvic organs like the bladder, the urinary bladder, the uterus, and the rest. No. Laparoscopy has the added advantage of being therapeutic apart from its diagnostic value. Laparoscopy is just normal procedure or elective surgery of the abdomen. When you open the abdomen up for surgery, you call laparoscopy. So contraindications. So if somebody has pelvic infection, or a woman is menstruating, or she's having pregnancy, or she's allergic to the dye used for the X-ray, then you are not supposed to do the HSG. HSG can lead to complications such as pain, perforation, hemorrhage. Hemorrhage means what? Rupture of blood vessels leading to internal bleeding, blood flow, and other things. Acute pelvic infections. So the HSG procedure can expose the woman to pelvic infection, acute ones, not the chronic one. They can also lead the woman to allergic reaction because some of the women react to the dye. Another procedure that can be done to solve infertility problems in women is the inspection of the uterine cavity by endoscopy. You know, endoscopy, we do endoscopy for duodenal ulcers, but we can also do endoscopy with access to the cervix to visualize the uterine cavity. And this allows for the diagnosis of intrauterine pathology, that's diseases associated with the uterus or the womb, and serves as a method for surgical intervention. So if you do the hysteroscopy, it can help the doctor to be able to know where an abnormality is, whether the uterine cavity is blocked, so that you can go and drain it or remove whatever is blocking it. Hysterocontrast sonography is an ultrasound technique developed to assess whether the fallopian tubes are open or blocked. So hysterocontrast, this one too, you take a contrast dye, and contrast that there is a dye that the woman will mix and drink. And if she's going to mix and drink that dye, her kidney function test should be good, because if your kidneys are not working well, your liver is not working well, you cannot be taking such dyes which are very, very radioactive, which can destroy you. So you have to be very careful. You have to do liver function test, kidney function test, to be able to know whether your body can excrete the dye, whether your reproductive system can really, your kidneys can excrete the dye, your liver can metabolize the dye. Yes, it's very important. So you take a contrast dye before the sonographer can be able to see inside your fallopian tubes and see whether they are blocked or open. Okay, so postcoital test. This one evaluates sperm competence and cervical mucus. You know, women, every woman has a cervical mucus block. Cervical mucus block. So in the cervix, there is something we call cervical mucus. So if this is your fallopian tube, fallopian tube. This is your fallopian tube. This is your uterus, your cervix. We have the external os of the cervix, the external hole of the cervix, internal hole of the cervix. We call it os, os, cervical os. Then we come to your vagina. Come to your vagina. But in the cervix, inside this os, there is a mucus that is blocking sperm from or anything from entering the cervix. We call this mucus cervical mucus block. mucus plug. So you realize that the sperm should be very active to be able to swim through the cervical mucus, and the prostate and the seminal fluid, the prostate fluid, they dilute the cervical mucus so that the sperm can travel past it and go to the fallopian tube here or the fallopian tube here. So the sperm should be able to swim from the vagina, bypass the cervical mucus. That's why the seminal fluid has substances that break down or thin make the mucus of low viscosity so that the sperms can travel through and go and meet the ovary. So this is the cervical mucus plug. So let's see. So postcoital test evaluates sperm competence in cervical mucus. It is done in the peri-ovulatory period, that's after ovulation, especially after sex. You examine the cervical mucus, and there are 3 tests based on the length of time elapsed postcoitus or after sex. There are 3 tests that are done. The standard test takes 6 to 10 hours after sex. The delayed test takes 18 to 24 hours after sex. The early test takes 1 to 3 hours. You just want to see whether the sperms are able to travel through the mucus, and how strong are they? Are they moving in an active manner in linear progression? So interpretation. So at the end of the cervical mucus, and this one is done in the woman. It is done in the woman to assess. So at the end you see the amount of the sperm, how clear the semen is, then the stretchability of the semen, cellularity, the number of sperm cells in the semen, then the motility or the movement of the sperm and their number. The test is losing popularity because of its many drawbacks. Another test that evaluates similar parameters is the in vitro cervical mucus sperm penetration test. It's the same test, but now we are doing it outside a human being, and it's a sperm function test which measures the ability of sperm in the semen to swim up into a column of cervical mucus. So this one, we bring an artificial cervical mucus column so that you see whether the sperms can swim past it. So that's it. So what do we do for a male? A male factor infertility, these are the investigations. The routine tests are FBC, sickling status, and LDS. You know the sperm have to get a lot of energy to swim, so the person should not be diabetic. The sperm also, the testicular artery needs to be supplied with, needs to supply the testes with blood so that sperm can be produced. Then specific tests that are done are semen analysis. So this is how it is done. So you need to, before you do the semen analysis, you need to abstain from sex for about 3 to 5 days. Then afterwards, you collect the specimen after the waiting period of 3 to 5 days without having sex. So the person has to abstain from sex for 3 to 5 days. Then afterwards, the person has to either do coitus interruptus or have sex and withdraw the penis into a container, a sterile container, and collect the sperm inside. You people, you know better than I do, so don't let me talk too much on this, because the women and the men all in this class are not, they are adults, they are not children. They are these are things that you people have been doing always. So, normal semen analysis, WHO reference values are: the volume should be between 2 to 5 ml. The pH should be an alkaline pH that's basic pH of 7.2 to 7.8. Liquefaction time should be within 30 minutes. That within 30 minutes, the sperm should be able to become liquid. Concentration of the sperm should not be more than 20 million per ml. So the concentration should be more than 20 million per ml. That's 20 million per ml or more than. It shouldn't be less than 20 million. Now, so they have even brought it to 15 million per mil because of stress and other related occupational problems. Motility is greater than 50% progressive motility, so the sperm should be able to swim and be active with linear progression. The morphology of the sperm means that the head should be intact, the tail should be intact, the middle piece should be intact. Every part of the sperm should be intact. So if a sperm has the head cut off, then it will not qualify for the motility test. WBC should be less than 1 million per mil. Higher than 1 million per mil means that the sperm, there is an infection in the semen. Abnormalities of semen quality. Okay, so if we say astenozoospermia, meaning that the person has defective sperm motility, the sperms are not able to move. Normozoospermia means normal sperm count. Necrozoospermia means that all your sperm cells in the ejaculate are dead or dead sperms. Teratozoospermia means that morphological defects. Your sperms, most of them do not have head, most of them do not have tail, so they are teratozoospermia. Terato means teratogenic substance. Things that you can, when a pregnant woman takes, maybe you are pregnant, you are taking alcohol and you are smoking and those things, it will affect the fetus in your womb, because alcohol and the drug abuse and other things are teratogenic substances. So if we have teratozoospermia, meaning that morphological defects. Morphology means that the body, the sperm may not have a head, may not have a tail. Azoospermia means absence of sperms. Oligospermia means low sperm count, that sperm count less than 50 million sperms per male of ejaculate. Oligo means oligoastenozoospermia, put it there, it's a combination of low sperm count and also defective motility. The sperms are not able to move well. This is oligoastenosis. So you have low sperm count, and this low sperm count, the sperms are not able to move well. Oligoteratozoospermia means you have low sperm count, and the sperms, most of them do not have head, most of them do not have tail, they have problems with their morphology. Teratoastenozoospermia means that asteno means that defective motility, and also terato means that they don't have a head, they don't have a tail, whatever, and they are not even able to move well. Oligoteratoastenozoospermia means the sperms have low sperm count, most of them are having morphological defects, and they are also not able to move well. These are the further investigations that can be done on the man. We have to do some hormonal workup. So luteinizing hormone, follicle stimulating hormone, testosterone, these are 3 hormones that affect spermatogenesis. Prolactin also provides information for specific cause. So LH, FSH, testosterone, and prolactin can affect the level of what? Spermatogenesis. Especially the prolactin is for women, so it affects oogenesis. And this one affects spermatogenesis. So these 3, LH, FSH, testosterone. So if their levels are normal, it means that it is good. You don't have any sperm problem. Your testicular function is normal. But if their levels are lower, it means that your testicular function is not good or it's not normal. So we can do karyotyping. We can karyotype or see your chromosomes and see. That's karyotyping. Check your chromosomes and see whether they are normal. And by this, we take your chromosome and we take a normal person's chromosome and we match them to see which one is normal. So we also do ultrascan of the scrotum to find out whether your testes are of normal size or not, and whether you have the content of your spermatic cord are within range, whether you have the testicular artery, papilliform, plexus, you have the genitofemoral nerve, you have all those epididymis and all those things, vas deferens, all in the spermatic cord. Then we also will need to find out whether you have normal size testes. We also need to do X-ray, CT scan, MRI of the pituitary, because the pituitary that regulates LH, FSH levels, testosterone production, prolactin. So we have to find whether the person does not have any pituitary tumor. Then seminal fluid, if your seminal fluid also produces enough fructose, because it's the fructose that the sperm will use, it will give them energy to be able to swim to the ovaries. Testicular biopsy is indicated for severe oligospermia and azoospermia. So if somebody azoospermia means that you don't have sperm at all. If you have azoospermia is here, absence of sperms. So that one is a serious situation. So with those ones, you do testicular biopsy to find out whether you take testicular biopsy means that you take a section of the testis, just a small piece of the testis, that's the tissue of the testis, and go and do histopathology to find out whether there is testicular function. So you take a biopsy of the testis. You take a biopsy. So you take a biopsy of each testis, because there are two testes. Each testis. So after taking a biopsy of each testis, now you want to find out that from the histopathology, so you do histopathology, study of diseases that are associated with tissues. Histopathology. You do histopathology, then after the histopathology, you want to find out whether there is testicular or normal testicular function. Whether the testicles are functioning. Yeah, so you have testicular function. Okay, so that is about it. So oligospermia, low sperm count, and azoospermia, you do this testicular biopsy. So if you see that the testicles are functioning normally, then the urologist, the urologists are medical specialists or medical doctors who have specialized urologists. They are medical doctors who have specialized in male fertility issues, male fertility or male reproductive system or organ issues, male fertility or male reproductive organ issues. While gynecologists are specialized in issues associated with female reproductive system. So gynecologists for females, then urologists for males. But scarcely have I seen any urologist who is a female. Most of the urologists are males, and most of the gynecologists are also males. So men, why are you interested in putting your two fingers in another man's wife's vagina? And you go and do that, when you come home and your wife expose her vagina to you, you say, wait a minute, this phenomenon. Then you will not be touching your wife. Why? Okay, so that's by the way. So I said seminal fluid, fructose, is supposed to help the sperm to be able to get enough energy by way of ATP into stream to the fallopian tubes into the ampulla region of the fallopian tube to fertilize the ovum. By this, we end the class here using these quotes. So those with azoospermia and oligospermia, if the oligospermia, you do it and still sperm is not coming out or fertility is not, there is no pregnancy, then you go and do IVF. So you go and do IVF, in vitro fertilization. You go and do in vitro fertilization, IVF. Or IUI, intrauterine insemination, IUI, or intracytoplasmic injection, which is also called ICSI. Intracytoplasmic injection, which is also called ICSI. So in our next lecture, we will be doing IVF, IUI, and intracytoplasmic injection, or ICSI. So these are the three things we are going to study. So we want to produce a human being in a test tube, in vitro fertilization. So we want to produce test tube babies. Test tube. We are going to create human beings in test tube. Test tube babies. A lot of babies we are seeing around are test tube babies. A lot of them. It's not all of them that went through the uterine phase. Most of them were produced in test tube before you put them inside a competent uterus. Most of them were produced in test tube before you put them in a competent uterus for the uterus to support their growth. So by this, we want to end the class, and we will meet on our last class. That will be on assisted reproductive techniques, where we'll be doing the IUI, that's intrauterine insemination, IVF, in vitro fertilization, and ICSI, intracytoplasmic injection. So without much ado, I want to end with this quote. Fertility of a couple is the sum of the fertility of both partners. It's true. You don't say that the woman is supposed to be fertile or the woman is barren. You can be a man and you can also be barren. A thorough history, examination, and investigations can lead us to a definite diagnosis, like what we did in the lecture. Infertility is treatable in most cases, but if you treat infertility and it's not able to treat, then you go for adoption. Go to the orphanage home and go and beg them that you need them to give you a baby so that you can take off. And some of these babies, when you adopt them, one day their mother and their father will come and say, hey, that is my child, oh, I need my child. Now, after you have used all your life savings on them, they will come and say, this is my child. But that is nature. So beloved, we want to end this section of the class. Infertility treatment over here. Thank you very much for being my audience once again. May God richly bless you as we meet next week for our lecture on assisted reproductive technology, IVF, ICSI, and intrauterine insemination. Thank you very much. May God bless you.